Hi, this is Dr. Akhtar Amin and welcome you to the quick revision of ophthalmology and optics. We will start from chapter eyelids, and the first topic is bacterial and viral infections of eyelids. The first infection is external hordeolum, commonly known as stye. It is caused by a bacteria known as Staphylococcus, and it causes abscess of the lash follicle. In picture you can see abscess of the lash follicle and the associated gland of Zeiss. The gland of Zeiss is associated with the lash follicle. So the hordeolum, external hordeolum and styes, they are common in children and young adults, and the risk factor is Blepharitis. Multiple lesions can occur along the lid margin, and the stye can also involve the whole lid. The signs and symptoms are tender swelling, and usually there is a lash at the apex of the swelling, and there is also a pus part. There may be scratchy feelings, there may be sensitivity, there is crustiness, tearing. So there may be multiple lesions, and the treatment is antibiotics. Oral antibiotics are occasionally given, and hot compression, and if there is lash, so epilation of the lash follicle. Another one is Impetigo. It is a superficial skin infection. It is caused by Staphylococcus aureus and also by Streptococcus pyogenes. The impetigo occurs in children and on the face of the children, in those children who have poor personal hygiene, and are also associated in children who have scabies. There is painful signs and symptoms are there is painful, and there is itchiness, and there is erysipelas macules which rapidly develops. There is rapid development into thin-walled blisters. So there is blisters, thin-walled blisters, and then these blisters develop into golden yellow crusts upon rupturing. So when the blisters ruptures, there is golden yellow crust formation, and there may be fever, malaise, and local lymphadenopathy. The treatment is with topical and oral antibiotics. Beta-lactamase resistant antibiotics, and preventive measures to reduce transmission. Why? Because the condition is highly contagious. It is particularly dangerous to neonates. So if there is contact with neonates, contact should be avoided with neonates. Another one is erysipelas, also known as Saint Anthony's fire. It is caused by Staphylococcus pyogenes. It is an uncommon acute, potentially severe dermal and superficial lymphatic infection. It is a lymphatic infections, superficial lymphatic vessels. It is caused by strep pyogenes, and it is a superficial infections. And the risk factors are diabetes, obesity, alcohol abuse. They are predisposing factors. There is, the signs symptoms are, there is inflamed erythematous flag, it develops. There is well defined raised border, the border is raised, and this distinguishes erysipelas from other forms of cellulitis. Complications such as metastatic infection. Metastatic infection are rare. Treatment is what with oral antibiotics, but recurrence is common. So this is erysipelas, and this is the lymphatic infection. And there is fever, shivering, chills, fatigue, headache, which occurs with every infection. Another one is necrotizing fasciitis. It is rare, but it is very severe infection, very severe. It involves the subcutaneous soft tissue and the skin. Subcutaneous soft tissue and the skin. And it is also caused by strep pyogenes, and occasionally it is caused by staph aureus. The most frequent sites of involvement are the extremities, and trunk and perineum, as well as post-operative wound sites. So unless early aggressive treatment is instituted, if there is no early aggressive treatment in the form of surgical debridement and high-dosed intravenous antibiotics, death may occur. And redness and edema are followed by this redness and edema. After 1 to 2 days there is pain and cyanosis, violaceous hues, and large bullae formation occurs, and there is black discoloration of skin due to necrosis. It can also cause decreased vision, proptosis, restricted ocular motility, and development of a relative apparent pupillary defect. So this is rare but very severe infection. The treatment is surgical debridement, high dose intravenous antibiotics, lateral canthotomy, and cantholysis. Why? To decrease intraocular pressure, and hyperbaric oxygen therapy. Now, so these were bacterial infections: necrotizing fasciitis, erysipelas, impetigo, and external hordeolum. Now viral infections. The first one is Molluscum contagiosum, and it is a skin infection. It is caused by pox virus. Pox virus is a human-specific double-stranded DNA pox virus, and it typically affects otherwise healthy children. The peak incidence occurs between 2 and 4 years of age. Transmission is by contact and subsequently by autoinoculation. There are multiple and occasionally confluent lesions. They develop in immunocompromised patients. And histopathology shows there is central pit and lobules of hyperplastic epidermis with intracytoplasmic inclusion bodies, also known as Henderson-Peterson bodies, that displace nuclear remnant to the edge of the cell. Bodies are small and eosinophilic near the surface and large and basophilic deeper down. The diagnosis is there are single or multiple, there are pale and waxy, and the shape is umbilicated nodules. They develop. There is white cheesy material, and the white cheesy material consists of infected and degenerated cells. It can be expressed from the lesions. The lesions in the lid margin, they may shed virus. They may shed virus into the tear film and give rise to a secondary ipsilateral chronic follicular conjunctivitis. Chronic follicular conjunctivitis. So unless the lid margin is examined carefully, the causative molluscum lesion may be overlooked. So the molluscum lesion may be overlooked. And what about the treatment? The treatment, spontaneous resolution usually occurs within few months. So wait for few months before shave excision or cauterization or chemical ablation or cryotherapy or pulse dye laser. So treatment may not be necessary, particularly in children, unless complications such as secondary conjunctivitis are problematic. So the tip in this is, in a patient, if there is chronic follicular conjunctivitis that does not respond to topical antibiotics, look for Molluscum contagiosum involving the lid margin. The next topic is Herpes zoster ophthalmicus, HZO. It is a common and generally unilateral infection. It is caused by varicella zoster virus. It will be discussed in chapter 7 in detail. It will be discussed in here we will just talk about that there is initially episode of chicken pox, which the chicken pox virus then goes to dorsal ganglion cells, and after decades there is recurrence of virus which causes vesicular rash. Incidence increases with age, trauma, immune suppression. The general features are, initially there is a prodromal phase. In prodromal phase lasts for 3 to 5 days, in which for 3 to 5 days there is rash. Initially there is a rash on the forehead, tiredness, the patient feels fever, malaise and headache. Initially there is itching and tingling and burning sensation. And there are skin lesions in the V1 and V2 areas. There is sharp vertical demarcation line at mid-face, and there are eyelid scarring, loss of cilia, cicatricial entropion and ectropion. Hutchinson sign, if there is involvement of the nose tip, it is a strong predictor of ocular involvement. In acute disease there is conjunctivitis, episcleritis, scleritis, acute epithelial keratitis, nodular keratitis, stromal keratitis, also known as interstitial keratitis, disciform keratitis, posterior uveitis, anterior uveitis, and scleritis. Intraocular pressure increase, neurological complications. In chronic eye disease there is neurotropic keratopathy. Treatment, as you can see, this patient after 1 week of treatment with oral antiviral treatment, intravenous acyclovir, ocular lubrication, systemic steroids. It should be given only in conjunction with a systemic antiviral. Symptomatic treatment in the form of cold compresses, topical capsaicin, analgesics, tricycle antidepressants, carbamazepine, gabapentin, plus minus cycloplegic agents. Another one is herpes simplex. Herpes simplex skin rash result from either primary infection or reactivation of herpes simplex virus, which was previously dormant in the trigeminal ganglion. There is initially prodromal, facial and lid tingling. Facial and lid tingling, which lasts about for 24 hours, is followed by development of eyelid and periocular skin vesicles. Skin vesicles occur, as you can see in this picture. They are confined to single dermatome, and individual lesions, they are similar in appearance. The distribution of the rash contrast with sharply delineated unilateral involvement in herpes zoster ophthalmicus. There is commonly an assuaged papillary conjunctivitis, discharge and lid swelling. There may be dendritic corneal ulcer. In atopic patient in whom skin involvement can be extensive and very severe, as you can see in this picture. Treatment: in many patients, the inflammation will gradually settle without treatment. So, for about 1 week, if the treatment is necessary, we can give topical acyclovir cream 5 times daily for 5 days. And oral acyclovir, famciclovir, valciclovir antiviral agents can be used. Antibiotics such as coamoxiclav or erythromycin may also be required in patients with secondary bacterial infection. This is particularly common in eczema herpeticum. Blepharitis. Blepharitis, chronic blepharitis, chronic marginal blepharitis. It is a common cause of ocular discomfort and irritation. In the poor correlation between symptoms and signs, there is uncertain etiology and uncertain mechanism of the disease process. They all combine to make the management difficult. So the management of blepharitis is difficult. Blepharitis is divided into anterior and posterior forms. There is considerable overlap and both types are often present. So there is mixed blepharitis. In blepharitis, there is inflammation, scaling, redness and crusting of the eyelid margin. So the chronic blepharitis is divided into anterior and posterior. The anterior blepharitis affects the areas surrounding the base of the eyelashes, while the posterior blepharitis is caused by Meibomian gland dysfunction, and there is altered Meibomian gland secretions. The anterior blepharitis, it may be staphylococcal or seborrheic. It is sometimes regarded as related more to chronic infective elements, and hence more amenable to treatment and remission than the posterior palm. An etiological factor in staphylococcal bacterial blepharitis may be abnormal cell-mediated response. There is abnormal cell-mediated response to components of the cell walls of Staph aureus, which may also be responsible for red eyes and peripheral corneal infiltrates. in some patients. The staphylococcal is more common and more marked in patients with atopic dermatitis. Atopic dermatitis. Seborrheic blepharitis, seborrheic, is strongly associated with generalized seborrheic dermatitis. Seborrheic dermatitis. It is characterized by involving the scalp. It involves the scalp and nasolabial folds and skin behind the ears and sternum. The posterior blepharitis is caused by Meibomian gland dysfunction and alteration of Meibomian gland secretions. The bacterial lipases, they result in the formation of free fatty acids. This increases the melting point of the meibum and prevent its expression from the glands. Contribute to ocular surface irritation and possibly enabling growth of staph aureus. Loss of tear film phospholipids. Loss of tear film phospholipids acts as surfactants. They result in increased tear evaporation. So there is increased tear evaporation and osmolarity. There is unstable tear film. There is persistent and chronic inflammatory conditions. This is persistent chronic inflammatory condition, and it is also associated with acne rosacea. There is a reaction to a extremely common hair follicle and the sebaceous gland dwelling mite known as Demodex folliculorum brevis in some patients. In posterior blepharitis, the mite can be found normally in majority of older patients. Older patients do not develop symptom of blepharitis. So these are the Demodex. Diagnosis, this is usually bilateral and symmetrical condition. There is no visual disturbance. Symptoms, they are caused by disruption of normal ocular surface function. Symptoms are due to reduction in tear stability and similar in all forms of blepharitis. Stinging is more common in posterior disease. Sting is more common in posterior. And there is poor correlation between severity of symptoms and signs. These other symptoms are burning, grittiness, mild photophobia, crusting and redness of lid margins. There is crusting and redness. There are remissions and exacerbations. Remissions and exacerbations. Symptoms are usually worse in the morning. Although in patients with associated dry eye, they may increase during the day. Contact lenses may be poorly tolerated. So these signs are due to inflammation and due to excessive bacterial buildup and due to tear film suppression by clogged Meibomian glands. The signs of the staphylococcal blepharitis and seborrheic. Sign of staphylococcal blepharitis, there are hard scales, there are crustings as you can see, mainly located at the base of the lash. There are collarettes which are cylindrical, collection around lash bases. There is papillary conjunctivitis, conjunctival hyperemia. There is in long-standing cases there may be scarring. notching of the lid margin, scarring and notching. In long standing cases known as tylosis, there may be madarosis, trichiasis and poliosis. In dry eye syndrome, tear film instability, atopic keratoconjunctivitis, impatient atopic dermatitis. In seborrheic blepharitis, there is hyperemic and greasy anterior lid margin, as you can see. The soft scales and adherence of blemishes to each other. Signs of posterior blepharitis, also known as Meibomian gland disease. There is excessive and abnormal Meibomian gland secretion, manifesting as caping of the Meibomian glands, orifice with oil globules. There is pouting, recession, plugging of Meibomian gland orifice. There is hyperemic and telangiectasis, posterior lid margin. There is pressure on the lid margin result in expression of Meibomian fluid. They are turbid and toothpaste-like. In severe cases, secretion becomes so inspissated that expression is impossible. Lid transillumination may show gland loss, cystic dilatation of Meibomian ducts. The tear film is oily and foamy. Tear film is unstable and froth may accumulate on the lid margin. Froth, you can see, are inner canthi. So the secondary changes: papillary conjunctivitis, inferior corneal punctate epithelial erosions, corneal scarring, vascularization. Vascularization include Salzman nodular degeneration, advancing wave-like epitheliopathy type changes, sty formation, marginal keratitis, and occasionally bacterial keratitis in contact lens wear, and plaque tunnel eye disease. Treatment: there is limited evidence to support any particular treatment protocol for blepharitis. Patient should be advised that a permanent cure is unlikely, but control of symptom is usually possible. The treatment of anterior and posterior disease is similar for both types, particularly as they commonly coexist, but some treatments are fairly specific for one or the other. Lid hygiene should be carried out once or twice daily. Initially, although compliance and technique are variable. Warm compress, it should be applied for several minutes to soften the crust at the base of the lashes. So baby shampoo or sodium bicarbonate for lid cleaning and remove crust, soap, alcohol, impregnated pads for lid scrubbing. Lid cleaning is performed mechanically. Mechanical removal of crust and other debris, scrubbing of the lid margin with a cotton bud or clean face cloth, dip in warm dilute solution of baby shampoo or sodium bicarbonate. Commercially produced soap and alcohol, impregnated pads for lid scrubbing are available and highly effective. Care should be taken not to induce mechanical irritation. When there is substantial Meibomian gland disease, the regimen may include expression of accumulated meibum by rolling the finger anteriorly over the lid margin. The putative action of lid hygiene against Demodex is via prevention of reproduction. Lid hygiene can be performed less frequently as the condition is brought under control. The role of antibiotics. Topical sodium fusidic acid, picetracine, erythromycin, azithromycin, chloramphenicol. It is used to treat active folliculitis in the anterior disease and occasionally used for extended period. Following lid hygiene, the ointment should be rubbed onto the anterior lid margin with a cotton bud or clean finger. The oral antibiotics. It includes doxycycline 50 to 100 mg twice daily for 1 week and then daily for 6 to 24 weeks. Other antibiotics are tetracycline, azithromycin 500 mg daily for 3 days for 3 cycles at 1 week interval. Antibiotics are thought to reduce bacterial colonization and may also exert other effects such as reduction in staphylococcal lipase production with tetracyclines. Tetracyclines may be more effective in the treatment of posterior disease and azithromycin in the anterior disease. Tetracycline should not be used in children under age of 12 years and in pregnant or breastfeeding women because they are deposited in growing bone and teeth. Patients should also be made aware of the possibility of increased sun sensitivity. Azithromycin 250 mg once or twice daily is an alternative. Role of plants and fish oil supplements have been shown to be of substantial benefit in some cases. Topical steroid, a low potency preparation such as fluoromethanol 0.1% or lotiperidol 4 times daily for 1 week is useful in patients with substantial active inflammation, especially papillary conjunctivitis. Occasionally, a higher strength preparation is used. Tear substitute and other dry eye treatment are typically helpful for associated tear insufficiency and instability. Tea tree oil. It has been suggested as a treatment based primarily on its likely activity against Demodex infestation. The optimal vehicle and regimen have not been established, but lid, eyebrow and periocular skin cleaning once daily with 50% scrub and application of 5% ointment, it has been described. Topical permethrin and topical 1% cream are oral 2 doses of 200 microgram per kilogram 1 week apart. Ivermectin have also been used by some practitioners. High temperature cleaning of bedding, the use of tea tree shampoo and facial soap and treating the patient partner may also help to reduce recurrence. Novel therapies, they include cyclosporine, pulse light application and purpose-designed devices to probe, heat and express the Meibomian glands. For example, lipiflotium in the posterior disease. Complications are treated specifically. The next infection is Phthiriasis palpebrarum. The Phthiriasis pubis, it is a crab louse. It is adapted to living in pubic hair, but it is also commonly found in other hair covered bodies such as the chest, axilla and eyelids. Phthiriasis palpebrarum. In the eyelid, it is known as Phthiriasis palpebrarum. Symptoms consist of chronic irritation and itching of the lids. Itching of the lids and chronic irritation. But the lice are often incidental discovery. Conjunctivitis is uncommon. Lice are readily visible, anchored to lashes. As you can see in the picture, lice have 6 legs. 6 legs rather than the 8 possessed by ticks. Ova and their empty shells appear as oval, brown, opalescent pearls adherent to the base of the cilia. base of the cilia. Treatment consists of mechanical removal of the lice and their attached lashes with fine forceps. If necessary, topical yellow mercuric oxide 1% or petroleum jelly can be applied to the lashes and lid twice a day for 10 days. Delousing of the patient, the family members, the clothing and bedding is important to prevent recurrence. Thank you so much for your time.